Hello, Nina。
代表你好，你们刚刚又断线了，是不是？
对，没有啦，刚刚不是技术问题，刚刚是因为我其实刚刚蛮早跟人氧测试 OK， 那后来因为听到你们对话，我就想说我们在办公室偶尔还有一些自己的活动，就先把镜头跟 microphone 关掉。结果突然，因为我把那个 laptop 移到左边去嘛，移回来的时候不小心就碰到那个画面就关掉了，
所以你不能乱动。
重新再对啊，现在算了，现在不动了。
你不要乱动。
不动了，因为现在时间已经快到，所以不动。
对，还有2分钟。Yeah.
对。
Yeah. We still have 2 minutes, so we will going to start our today's online seminar 2 minutes later. So thank you very much for all of our guests from Taiwan and from Papua New Guinea. And I would like to check 卫福部的季监有没有在线上？卫部季监，人阳有一个麦克风，是不是要关掉？是。这个要关掉，是谁的？Well, everyone is ready. So we are going to start today's seminar. Okay, good morning, good afternoon, ladies and gentlemen. Thanks to join today's online seminar. I'm Nina, the Director of Overseas Medical Mission Center of Changhua Christian Hospital. I'm also the moderator of today's seminar. First of all, I would like to thank our distinguished guests, participants from Papua New Guinea and Taiwan, and our 3 speakers, Dr. Wang, Dr. Chen, and Dr. Damien. Before we start our seminar, I would like to invite the distinguished guest to give the remarks. So first, I want to invite the representative of Papua New Guinea Trade Office in Taiwan, Mr. Tommy, to give remarks. Tommy, please.
Good morning. Thank you, Nina. Good morning. I hope you can hear me.
Yes.
Yes, we can all hear you.
Good morning, Taiwan, and good day, Papua New Guinea. I'm Tommy Kunji, the representative at the Papua New Guinea Trade Office here in Taiwan. Let me firstly acknowledge our distinguished participants, especially Dr. Nina, CEO of Overseas Medical Mission Changhua, and our moderator of this online seminar, Excellency Ambassador Oliver Liao, representative Taipei Economic and Cultural Office in Papua New Guinea. This Liling Liu, Consular Ministry of Health and Welfare. Our esteemed speakers, Dr. Damien Asola, Dr. Wang Hai Fu, forgive me if I did. Chen Hao, and our distinguished
Tommy, we can hear you. Huh? Close the microphone.
Can you hear me now?
Yes.
Can you hear me now?
Yes, go ahead.
Okay.
Thank you. Thank you, Changhua Christian Hospital and the Port Moresby General Hospital for organizing this webinar on another health topic, kidney stone. I also acknowledge and appreciate the support of the Ministries of Health and Welfare and the Foreign Affairs of Taiwan for their support of this online seminar and the previous one. Taiwan has been and continues to be an invaluable and indispensable partner in the health sector of Papua New Guinea. This seminar and the previous one shows this, and also shows that disease knows no political boundaries and are common to all people, and that Taiwan and Papua New Guinea have common diseases, but different methods of management. Through this seminar and the previous seminars and presentations by our three esteemed speakers, we can share and learn of the experiences and challenges of kidney stone management in Taiwan and Papua New Guinea. I wish this seminar be successful in enlightening all of us and enable further collaboration and changes between Taiwan and Papua New Guinea. Thank you.
Thank you, Representative Tommy. And the next, I would want to invite Councillor Liu on behalf of Ministry of Health and Welfare to say a few words. Yeah, Councillor Liu Jijian, please. 期间我们没有听到你的声音。
现在有听到吗？有吗？
有，很清楚。您说。
这关掉回音。Dear Representative, Mr. Tommy Kanji, Ambassador Oliver Liao, and Dr. Nina Kao, distinguished guests from Papua New Guinea and Taiwan. Ladies and gentlemen, good morning. It is my great pleasure to attend the Taiwan and the PNG online seminar on kidney stone management and welcome all of you to this event. I would also like to take this opportunity to wish you good health in this pandemic era. The PNG in Taiwan's important ally is in South Pacific region. Over a decade, our ministry has worked with the Ministry of Foreign Affairs and the Changhua Christian Hospital to conduct the PNG medical program, which includes projects like mobile medical services, medical personnel training, and so on. During the pandemic, regarding medical personnel training, Changhua Christian Hospital not only transformed the on-site clinical training to online training courses, but also received Dr. Damien from PMGH to take urologist training since April at the urology department of CCH. Today, he will share what he learned in the 3 months of productive training. I hope the people in PNG will benefit from Dr. Damien's professional knowledge after he returns to PNG. In conclusion, I wish these seminars a great success and hope you all enjoy it. Thank you very much.
Thank you, Councillor Liu. And the next, please welcome Representative Liao from Taipei Economic and Cultural Office in Papua New Guinea to give remarks. 要代表。
Thank you, Nina, and good morning or good afternoon to all the participants of this online seminar. Can everyone hear me well? Okay.
Very good.
Okay. First of all, I'd like to say that it's again a great pleasure and honor to address this online seminar. I believe this is the second seminar held by Changhua Christian Hospital and Port Moresby General Hospital just very recently. And I believe that the speaker from PNG side, Dr. Damien Hasola, is probably also the first PNG medical doctor who went on a trip to Taiwan on a 3-month exchange program between Changhua Christian Hospital and PNG Port Moresby General Hospital. I'm glad that he can share some of his observation in terms of the kidney management and also try to exchange his opinion with our medical doctors at Changhua Christian Hospital. I would also like to acknowledge the goodwill and close collaboration between Changhua Christian Hospital and Port Moresby General Hospital, and I hope the bilateral cooperation on medical services between Taiwan and PNG, or more specifically, the cooperation between Changhua Christian Hospital and Port Moresby General Hospital will continue to grow. And I also hope that more similar exchange programs between our two sides will be continue to be conducted in the future. Finally, let me wish today's online seminar a great success. Thank you all. And before I go, may I ask you to do me a favor? Can everyone try to turn on their camera for just a second? Because I want to print the screen and get a good picture of today's participants. Thank you.
Thank you. So could everyone turn on your camera and smile?
Yeah, please turn on your camera so that we can get a good picture. We want to print the screen.
Yes. So say hi. Yeah,
Yeah,
before the
look,
camera. So
hello.
1, 2.
And Councillor Liu.
Okay.
Okay.
So
Yeah.
1, 2, 3. Smile.
Thank
okay?
you.
Okay.
One
One more.
more.
1, 2, 3. And could you have thumbs up? 1,
they're gone.
2.
Okay, thank you.
1, 2, 3.
关掉。
Good.
他们关掉. Yeah.
Okay.
Okay.
Thank you. Thank
Okay,
you.
thank you.
Yeah, thank you, Representative Liao. Yeah.
Thank you.
Okay, thank you. So thank you very much for all our guests. Then we are going to start our seminar. Yeah, I think everyone knows that the kidney stone is one of the most common urological condition in the Western and non-Western countries. So it is a huge burden, and if you delay treatment, it's becoming an issue worldwide. The prevalence has increased over the years, affecting the developing country, leading to complications such as infection and age of rental value. So today, we invite doctors from Taiwan Changhua Christian Hospital and Port Moresby General Hospital to highlight the challenges and introduce new concepts to management the kidney stone. The first speaker is Dr. Wang. He is the chief of Uro-Oncology Center of Changhua Christian Hospital. So his topic is general practice of urolithiasis management at Changhua Christian Hospital. Dr. Wang, the floor is yours, please. Microphone 没开，王医师麦克风没开。
Okay, thank you. Many thanks to Dr. Carl's nice introduction. Yeah, first of all, I'd like to congratulate Joseph to finish his training in our hospital. Okay, since I only got 15 minutes, I make a general introduction about urologic management at our Christian Hospital. As I can find the historical evidence, the first description was made by Hippocrates in 4th century BC, and the origin is here. And he stated This urolithiasis was found in human in an Egyptian mummy, and the first operation, so-called perineal lithotomy, was performed by Shushrat in the 12th century BC. As you see, so many efforts have been made to make the stone management easier, successful, and minimal invasive. I think this will be the trend, the worldwide trend, and it should be the future. Urolithiasis can be classified according to the etiology, composition, size, location, and also by image. As you can see, in old days, doctor will operate for kidney, so-called stake-home renal stone, and big vesicle stone. I think the delay of diagnosis will make such big stone, and so of course the most important thing is to make early diagnosis and perhaps some prevention effort. So what doctor should do when patient come to you? You should make a thorough history taking and physical examination, of course, laboratory examination and image studying. This is we frequently use sonography because it's easy, it's convenient, and without radio activity. You can see just with sonography to detect the renal stone. Of course, it causes acoustic shadow that we can make differentiation between vessel and other spot lesion. And this is a vesicle stone, as you can see again, the acoustic shadow and the stone. Of course, if you don't see the acoustic shadow, it could be a cancer. And apparently, the sonography can identify obstructive uropathy. This is so-called hydronephrosis, and it could be caused by obstruction in the urethral level. And this is a plain KUB. KUB means kidney, ureter, and the bladder. Any abnormal or radiopaque density on the urinary tract should be considered as a urolithiasis. This is not an intravenous pyrography. Intravenous pyrography was taken X-ray before and after injection of contrast medium, but this picture is not taken. It's taken before intravenous contrast medium injection. So you can see the radiopaque density already exists before contrast medium injection. So this is where it exists, and a very huge, very diffuse stake-home bilateral stake-home renal stone. So when you encounter the picture of such a patient, you should consider there must be some medical problem. So why, as we can see the stone history, maybe we can detect almost 5,000 years. That means it won't disappear. It will still bothering our human. So if you encounter such kind of stone, you have to watch out. There must be some medical disease. Most frequently, hyperparathyroid hormone. Thyroid hormone, parathyroid hormone is responsible for calcium metabolism at most. So if it got problem, the abnormal calcium deposition in the kidney will result in such a disaster. So please take care of such kind of patient. And a vesicle stone always ovoid or round in shape. It's a different story from renal stone. If you see such kind of stone, you can see the stone was elevated up over the bladder. Why? The bladder is empty. Why it is elevated? You should consider there could be some benign prostate enlargement to push the stone upward. Of course, is the reason why patient get vesicle stone, not renal stone, because the urinary stasis and the sediment will cause vesicle stone in the long term. Usually is wrong or avoid because it's always rolling, and become a big stone. And this is intravenous urography after contrast and medium injection. You can see the urinary tract through the contrast enhanced, and this is urinary bladder. So these are not stone. This the picture of the contrast medium, and also you can detect any obstructive lesion. This is maybe a urethral pelvic junction obstruction here. See the pathway of ureter. So this is what we usually do before. Recent years, the concept of non-contrast or maybe contrast CT scan is become more and more popular for detection of stone. Why? A patient with stone always come to emergency department because of colic pain. It's not easy. It's not suitable for you to perform intravenous urography right in the emergency department because patient is very painful, and of course many pain is resulted from different etiology. So in the emergency department, they would be clever to make a non-conscious CT, especially for kidney stone, because it got a radio opaque density already. You don't need contrast medium. If you consider other problem, of course, you can add contrast medium with CT scan. Anyway, only non-contrast CT scan will be enough for a stone detection. See, even very small urethral stone causing colic pain can be detected sharply, can be detected precisely. It's a novel idea for application of CT scan. Before we don't suggest that because the radioactivity, because of the expensive cost and many other reasons. But nowadays, more and more doctor can accept this, and even it was written on the guideline. Okay, how about MRI? As we know, MRI cannot detect stones without without the nuclear activity. So MRI is maybe for pregnancy because it didn't show on the MRI picture. So you can see the stone may be low intensity. This is a urethral stone. This is a pregnant woman. It's a baby, her baby. So if it got a renal colic, as reported, the incidence of urology will be increased during the third trimester of pregnancy because the metabolic rate is getting higher and the stone incidence is increasing during the third trimester. Even the women don't have the history of urology before. So this could be considered MRI for pregnant. Okay, about the management, the first management we like to use is extracorporeal shockwave lithotripter. It is invented and produced the first extracorporeal shockwave lithotripter in 1985. Fortunately, Taiwan, we have the first lithotripter in 1988. It is a very interesting invention. It just used the shockwave to fragment the stone and let the patient pass a stone out by himself or herself. It's quite easy and quite non-invasive and success with very good success for about 80 to 90%. There's a small story about the first shockwave lithotripter. It is produced by the Dornier company, Dornier Industry. As we know, Dornier's industry make airplane. And the first generation lithotripter, they use a bomb lifter to lift the patient into the water tank because the shockwave needed to be transmitted with the medium of water. So this is the first generation lithotripter. Why use the bomb lifter? Because they make plane and some pilot feel the shockwave from outside the plane when the bomb attack them. But the airplane was not attacked, of course. They found the shockwave could be used to impact the object in in a distance. So this is a very interesting finding. So Donier Industry invent their first shockwave light source treater just by the exist equipment of the the bomb lifter in the bomber, the plane. Okay, so another is the ureteroscopic. Usually we use rigid ureteroscopy, retrograde, just enter from the urethra ureter into the urethral phase to our target, usually the ureter lesion. Sometimes you can see the renal stone here, but only in the direct, only in the through direction. You cannot turn away. You cannot just flex the rigid scope. So it got some limitation, but for most urethral stone, it's okay. Don't see the small things here. It sometimes is dangerous. Some complication was made by ureteroscope. Maybe Dr. Chen, what he will talk about the complication of stone management later. Okay, nowadays we improve the ureteroscopic technique into retrograde intrarenal surgery. That means we use flexible ureteroscope rather than rigid ureteroscope. And of course, you can use a rigid ureteroscope antegrade or a flexible ureteroscope antegrade through the percutaneous nephrostomy. You can do some intrarenal surgery, not only for stone, because you can use this instrument to destruct or destroy renal pelvic or calyx tumor as well. Only for early stage small tumor. And of course, a more advanced technique, we can combine a retrograde flexible ureteroscope and antegrade percutaneous nephroscopy to do the combination therapy for huge renal stone or complex renal stones, so-called ESERs. This is the picture of flexible ureteroscope. As you can see, the biggest angle could be 270 degree. So you can visit all the calyxes in the kidney. As you can see the picture, this is a calyceal stone with the tail, and this is another calyx. Of course, you need to use fluoroscope, so-called C-arm, to localize the position of your ureteroscope and maybe some accessory instrument as a double J caster or guide wire. This is the picture when you use a flexible ureteroscopy through the urethra. And this is a picture of ESERS. You're prepared, patient prepared to receive the percutaneous nephrostomy. We use a nephroscope here and a flexible ureteroscope here to combine to treat the complex renal stone. If for simple percutaneous nephrostomy, we got a tract, a small tract. Nowadays we can minimize the tract. Maybe that's less than 5 millimeter only, and thanking to the fine resolution and the good facility, a smaller track, smaller maybe forceps scope. So as you can see, the big stone could be removed on and after fragmentation through a small tract, only about 5 millimeter to 1 centimeter, to empty the and return the kidney space back to normal. This is caster left finally. Okay, this is my talk today. Just feel free to ask in the discussion. Thank you all.
Thank you very much for Dr. Wang's great presentation. So the next speaker is Dr. Chen, and he is attending physician of Department of Urology of Changhua Christian Hospital. And Dr. Chen will present the surgical complication for stone disease. Dr. Chen, the floor is yours, please.
可以吗？Okay, we're getting everything set up right now, but I'd like to first thank Dr. Damien. He's very professional in his stay doing here, and it was a great pleasure talking to Damien about the different hospitals and. Huh? Okay, 好，谢谢。It was a pleasure talking to Damien and letting him know about our hospital and how we treat our disease in urology, and hopefully in the future we can do some kind of cooperation because Damien has a lot of interest in transplantation also. So I'm also a board certified transplant surgeon. So if there's any cooperation in the future, it would be greatly pleasure to have Damien for cooperation in the future. So I would like to thank everybody for the invitation, for being a speaker in this topic. And my topic for today is complication in endourology. So I'm just gonna get started. So basically, I'm going to talk about the basically complications in endourology and maybe offer some prevention and management for different complications. So when you start first doing endourology, it's you can read a lot of paper and a textbook, but as you can see, there's thousands of journals are about the complication in endourology. But I think the most important is the experience. If you get a decent if, if you can get experience in an experienced hospital and get to know how to do the surgery, I think that's more important than reading all this paper because at the end, you still need the experience and hands-on to know how to treat and to avoid these complications. So my sources are the Campbell Urology and the EAU Guideline 2020. So first we will talk about the preoperative, what kind of things can go wrong preoperatively. So first we'll talk about the renal colic and the pain for the patient. So according to the guidelines, so there's a lot of medications that you can use. Personally, from the experience, if the patient has renal colic, NSAID is unless the patient has some type of ADR or adverse effect to previous NSAID. I think NSAID is the main pain medication for these patients. And if they have any allergies, and I think opioid is an option, but guideline doesn't recommend Pacidine because that might have and also type of you can get addicted to Pacidine. So most likely other things like morphine or naproxen will be more recommended for these patients. And also antispasmodic also agents can also help. You can inject buscopan or piperzolam. So that also help with the patient's pain. And personally, I also use alpha blockers. According to guidelines and journals, for tamsulosin, they can help with the pain and also help with the lower ureter stone. It can help with the passage. So in these patients, I personally would do a combination of NSAID, piperzolam, and tamsulosin to help with the pain. And we don't recommend it to long term unless the patient doesn't want to get any intervention. So basically, it's kind of like a bridging therapy between his pain and the definite treatment. And also, we don't recommend long-term use of NSAID that can cause maybe renal function impairment, and also there are studies about causing CV-related risks. So we don't do long-term. So basically, long-term or basically use piperzolam and tamsulosin. And if the patient has pain, we do PRN for the NSAID for the pain. And for the bridge toward the renal colic, so we can either use as Chief Wang previously previous talk let us know the interventions such as ESWL, ureteroscope, or PCNL to relieve the pain that caused by the renal colic. So these are the guideline, the recommendations for the pain management. Also, the NSAID is very effective. You can either use the IM injection. Usually, patients during the OPD hours, they experience really pain. So one shot is really relieve his pain dramatically. So other non-steroid inflammation, you can use other like diclofenac, ibuprofen, and opioid is really weak, so I recommend either use NSAID if he doesn't have any allergic reactions, or maybe do like a antispasmodic like Buscopan for the pain, and then bridge toward the decompression. You can either use a ureteroscope or other form of decompression. Okay, for the medical expulsion therapy, also recommended that using for the stones larger than 5 millimeters, it's helpful. And previous, I think 5 to 10 years ago, they also recommend using like steroids or calcium channel blocker, but recently, I guess the alpha blocker will be helpful, and it has been shown to evidence for the distal ureter stones greater than 5 millimeters. So for my prescription, I'll use NSAID plus maybe like antispasmodic plus the alpha blocker. So that's for the renal colic part. So if the patient can get through that, if he has obstruction and infection, what can we do for these patients? So preoperative, if the patient has obstruction, and also we have to see if he has more seriously, like say sepsis, or if he has bilateral obstruction, then maybe that's the urological emergency. We need to get rid of the obstruction ASAP. So decompression, you can either use ureteral stent or PCNL, and which one? A lot of people ask which one, especially my residents. They ask which one do you choose? I say, according to the evidence, either one is okay, as long as your experience tells you which one you're more inclined to do. So personally, I'm very experience in PCND. So during our surgical resident days, we do PCNDs routinely. So I'm more experienced doing PCND. So for these patients, I think PCND for me, I can do relieve the obstruction much better, and contrast the patient's sepsis much better. So besides that, also if the patient has sepsis related complications, we recommend doing doing the sepsis bundle, getting blood samples, urine samples, and any samples that you can think of, just to for the later control infections. So that would be helpful. So also the EAU guideline, also a strong recommendation to emergency decompress in case of sepsis. So you can either use ureter or PCND. For personally, I think PCND is much faster. I can control the patient much better. So I usually do PCND for my patients. And any antibiotics depend on what kind of resistance that you have in your country. So it varies. For us, we usually start for a severe case of sepsis, we usually start with a 3rd gen cephalosporins will be sufficient to control these patients. And yeah, so we just obtain the cultures for the blood and urine, and we can adjust the antibiotics later. So that's before the surgery. So what happens during the surgery? So first we'll talk about intrarenal surgery. As Dr. Chief Wang just said, the intrarenal surgery includes PCNL and a flexible ureteroscope. So I like to say sorry to Damien. We had several PCNL lined up for him to look, but it was kind of bad timing because recent month we have a surge in COVID, so a lot of our patients they stopped the surgery, so they couldn't come in for the PCNL. So I'd like to say sorry to Damien, so we couldn't show more PCNL for him to get more experience. But PCNL, mostly our endourology has minor complications such as fever and bleeding. Usually they are self-resolving. We rarely require like blood transfusions or sepsis. Our sepsis rate is like less than 1%. That patients that can need to go to the ICU. So most of our minor complications are fever and bleeding. That's about 10 to 25% of the patients. The major complications, a lot of textbook and journals, they have all these complications, but I think it's more if you have more experience doing it. Hydrothorax, pneumothorax, as long as you don't go over the 12th rib, it's really hard to get pneumothorax. Textbook tell us about if you do intercostal puncture between the 11th, 12th rib, you risk about 10 to 20% of puncture. If you do higher, that's close to 100%. So usually our puncture is lower than the 12th rib. So usually we don't get these complications. Let me see. Sepsis rate is also really less. We get about like less than 1% of sepsis that requires ICU stay. So PCNL also preoperative, you have to check for patient's coagulopathy. If he has coagulopathy or active infection, we usually don't do. Usually, you don't do that kind of surgery for these patients. Also, for anticoagulants, we stop the patients. We suggest them to stop around 7 days. If they need it, if they have usually like a stent or recent CVA, we also recommend doing the low molecular heparin as a bridging therapy. So preoperative, we also do blood, simple blood work and also get a urine culture. I think that's really important. So if he he happens to have sepsis in post-operative, we can use the urine culture for our antibiotics. Imaging. Dr. Chief Wong also explained. So I recommend doing a CT because CT can actually give us anatomical planning preoperative. So that's really helpful. And antibiotics, especially for large stack-on stones, I suggest doing oral antibiotics and along with the IV antibiotics 30 minutes before operative time. That will be helpful for prevention for the infection. And also, these are the Campbell urology. They are recommend using first or second generation cephalosporin. And you can also use other antibiotics. I think according to what is the resistant trend in your country, I think we do. Usually in Taiwan, we usually do first to second gen cephalosporin will be sufficient. So these are the pleural complication, just as I explained earlier. So this is the pleural anatomy. So usually we do punctures below the 12th rib. So it's a shame that we can show Damien when he was here. I had like 2 or 3 PCNL lined up, but the patient canceled due to COVID. So I have to explain using the slide. So basically our patient was in prone position, but recently I switched my patient to do supine PCNL for the past 5 to 10 cases that had good experience with supine. So I'm most likely switching to supine for these patients because first it's easier. We don't have to shift the patient too much, and also patient doesn't get into prone position, which also complicates the lungs. So I'm switching my patients to supine position. But I think I first started learning the prone position. So our position when we puncture is usually below the 12th rib. So you can see if you puncture below the 12th rib, and also I'll usually just target toward the 12th rib, the tip, the region. so around this region. So if you want to puncture a rib, the pleural is really close to 0. And if you do like a 11 or 12 rib puncture for a different anatomy, or if you want to do the upper calyx puncture, you risk around 10 to 20% of pleural injury. So, but it can be done. We do it sometimes. We usually, if you planning on doing the intercostal puncture, you have to basically mark the 12th rib around. If you measure around like in the middle, and usually you puncture between the 11 or 12 rib, the tip region, to minimize the chance of pleural injury. So that's my suggestion. But if you start doing the PCNL, I suggest doing the 12 rib puncture. It will be more safer for the patient. And once you learn prone position, you could do supine position, because the most of us start learning from the prone positions because we can do eye of needle puncture, like as the textbook suggests us to do. And I was gonna show Damien the eye of needle puncture, but the patient canceled, so I have to say sorry to Damien, so I couldn't show him that puncture. But the colon complications we sometimes encounter, but it's really rare because it's
Dr. Chen, 2 minutes.
Oh, okay. So the colon complications, unless you have these anatomies, usually before, if you do CT scans, you can basically you can avoid this colon complications. So the flexible ureteroscope, I think mostly you have to be careful about sepsis. So sepsis, the preoperative actual anticoagulants, the preoperative evaluation. So intraoperatively, we usually keep time for the intrarenal operative time. So once we enter the kidney, I have the circulating nurse time us. We usually don't do over around 1 hour of surgery. So sometimes the stone is really big, so we recommend the patients to do maybe 2 or 3 surgeries afterwards. So just for the safety of the patient. So if you do it longer, you risk more of an infection. For the ureter, it's really simple if you do it plenty of times, but I think guide wire is your best friend. So I usually teach my residents just follow the lumen, and if you see fat, just don't go in there. Just if you see the mucosa, it's just follow it through. So basically use the guide wire as the guide to go into the ureter. So there's a lot of complication. Usually it's pain for the discomfort from the stent. So injury is really rare if you follow through the mucosa. So usually just use the guide wire, you can prevent a lot of these injuries. So that's like my last slide. So at the end, basically you just know the difference. You have to keep in mind these complications, but I think the most important is the experience that you can get. If you can go to the hospital with a lot of experience, you can see more, you can do more. I think that will help prevention a lot of cleaning up the mess later. I think that's, and every procedure, I think you get a standard operating procedure for each surgery, so that can help with the prevention in the future. So I guess that's my slide for today, and thanks everyone.
Thank you very much. Thank you, Dr. Chen's great presentation. So our last speaker, the last one should be the best one. So the last speaker is Dr. Damien from Port Moresby General Hospital. Dr. Damien had his training at Changhua Christian Hospital for 3 months, and the training is almost finished. So today he will going to share what he learned at CCH. Damien's talk is kidney stone management, challenges of management kidney stone in Papua New Guinea. Damien, the floor is yours, please. Damien, go ahead.
Thank you, Dr. Nina. My presentation today is on challenges of managing kidney stones in Papua New Guinea. Patients with kidney stones in Papua New Guinea present with intense pain on either side of the lower back, nausea and vomiting, hematuria or blood in the urine, and fever and chills if infection is present. Kidney stones can be diagnosed with ultrasound scan, plain X-ray, IVP, and a CT scan. You can see on this slide how the different modalities can be used to diagnose kidney stones. Blood test and urine test can also be done to exclude any infection. Small stones may leave the urinary system when urine is passed.
This is a cursor.
For medium-sized stones, they can cause obstruction and pain, as you can see on this plain X-ray. Immediate management will include NSAIDs like ibuprofen or Voltaren and muscle relaxants. If urine reveals infection, then antibiotic is given. Hydration is also encouraged for these patients. In PNG, we don't have a shockwave lithotripsy for medium-sized stones. Small stones, 0.5 to 2.5 centimeter. Extracorporeal shockwave lithotripsy is offered to these patients at CCH. It is a challenge to manage big kidney stones in PNG. We also call them staghorn stones. As you can see on this plain X-ray, a left staghorn kidney stone. In PNG, management is usually symptomatic. If they present with pain, we give them pain medications. If they present with infection, then we treat the infection. Open surgery is an option, but it is associated with complications such as bleeding, leading to high mortality. For big stones or staghorn stones, PCNL is recommended at CCH, as Dr. Chen and Dr. Wang has mentioned. You can see on this diagram how PCNL is performed. This is a short video showing you a C-arm-guided PCNL. You can see a left kidney stone, followed by a puncture needle into the kidney calyx, and then a guide wire is inserted. You can see a stone there. And then different dilators are used to dilate the tract into the kidney calyx. This is followed by a balloon dilator, which is inserted into the kidney calyx. The balloon is inflated, and then a sheath is placed into the kidney calyx. You can see the balloon dilator being removed, and a nephroscope is then inserted through the sheath to commence stone fragmentation. You can see there is no more kidney stone on the left side. This slide shows you before and after PCNL. You can see before PCNL, there's a kidney stone visible. As compared to after PCNL, there is no more kidney stone. So it's a very good procedure to remove kidney stones. PNG needs to be able to perform shockwave lithotripsy for medium-sized stones and PCNL for large kidney stones to reduce the burden and challenges of kidney stones. You can see on this slide how shockwave lithotripsy is performed at CCH. I learned the following during my attachment at CCH: robotic and laparoscopic surgery, shockwave lithotripsy, PCNL, bipolar TURP, laser and enucleation, endourology, oncology, urology guidelines. And also I was fortunate to learn about kidney transplantation, pre-renal transplant HLA typing, and post-renal transplant immunosuppressive drug monitoring. In conclusion, these are invaluable skills that I've learned, which I will be able to share with my colleagues in managing some of the challenges posed by kidney stones and other urology cases in PNG. I would like to sincerely thank the following for their support: Department of Urology and Renal Transplantation, CCH, Department of Laboratory Medicine, Nephrology Department, Overseas Medical Mission, CCH. I want to take this time to thank Dr. Nina for her support and her team during the time of my attachment. Government of Taiwan, National Department of Health, and Department of Surgery, Port Moresby General Hospital. I know they're watching now, and I want to thank them for their continued support. Thank you very much for your attention.
Thank you very much, Dr. Damien. So all of our three speakers have finished their presentation. Now we are open for Q&A. I would like to know anyone would like to ask question, because I know we have Nongka Hospital, our good friends, online. They have some of our good friends. Thank you very much to join today's online seminar. Could you say, Verena, are you online? Yay! Thank you very much. That's good. Good to see everyone. Wish everyone will be still healthy and safe. Any question from Nongka? Maybe next time we will invite the Nongka Hospital staff to share some of experience. Okay. And I know that Port Moresby General Hospital, Dr. Baki is online, right? Dr. Baki, would like to say a few words or feedback? Good.
Okay. Thank you. On behalf of the surgical department here, we're pleased to see our colleague, senior colleague, Dr. Hasola, presenting on the challenges that we have here. Sitting here on my right is Professor Kebao. He is the official professor here in surgery who is in charge of our training. He is also present to witness Professor Dr. Hasola's presentation, of course, and our presenters from CCH. We pleasure and we appreciate the time and effort put into this, and we're glad to join you guys this afternoon here in Papua New Guinea.
Thank you very much. Professor, would like to say, Okay. Anyway, thank you very much. So I hope that after the pandemic, there are more medical staff from Papua New Guinea, including Nongka or Port Moresby General Hospital, can come to Taiwan for training. We hope that we have more. We're looking forward that we have more interaction in the future with Papua New Guinea, including Port Moresby General Hospital, Nongka Hospital, and even other hospitals as well. If there is no question, because time is almost up, so I'm going to close today's seminar. So once again, thanks all of our participants to join us, and I sincerely wish all of you safe and healthy, and I hope looking forward to seeing all of you very soon in the future. Thank you very much. Thank you. Bye.
Thank you, Nina. Bye-bye. Thank you.
Bye. Thank you.